the second topic, which is a pretty important topic again for us, is beta blockers in cardiology as a pendulum swung the other way. This has been taken by Dr. Eric Borges, sir. He's from Mumbai. So
इतना पूरा दिखाना लगातार कांस्टेंट, ठीक है, हिलाना मत इधर, पीछे हो जाओ. Okay, can you hear me? Hello? Am I audible?
Angiography, Indo-European Interventional Council, Cardiology Society of India. He's also the founder for the course chairman for International Cardiology Teaching Course, that is the Indo-European Course of Revascularization for Young Interventional Cardiologists, which is also accredited by the European Board of Cardiology and is also in collaboration with the American Cardiology Association. Sir has performed over 10,000 coronary angiographies and more than 5,000 coronary angioplasties and stent in India. He was involved with Professor Alan Creeper during the time of innovation of novel technique of transaortic valve implantation. His expertise in non-surgical valve replacement is way back in 1996 and 98. Welcome, sir. Let me also introduce our second speaker for today evening, Professor Eric Borges, sir. So he's presently a professor in cardiology and a senior cardiologist at Bombay Hospital, Mumbai. In his various appointments, sir is appointed as a cardiologist for the government of Mauritius, where he established the first cardiac center there. He's also a cardiologist for the government of Tanzania and is exploring the setup of possibility in Dar es Salaam, their capital. In Maharashtra, sir is an advisor to the government of Maharashtra for setup of cardio hospitals in Kolhapur and Nagpur. He is heading various committees which are tasked with audits of various government cardiac centers, and he's also a member of the St. John's Ambulance State Committee. Sir is also a chairman to the King George V Memorial Trust, which is an infirmary of 100 beds and partners with 8 NGOs across central Mumbai. He's also part of the management of Campion School, Mumbai. Sir is an author, contributing author to the API textbook of medical therapeutics and textbook of pediatrics. He is a referee for the articles published both in API, the Association of Physicians of India, and CSI, the Cardiovascular Society of India. So primarily he has been a co-author as well as a primary author for several papers which have been published in national as well as international journals and a part of various international conferences. Sir has conducted more than 30,000 angiograms, including pediatrics, and 7,000 angioplasties, with more than 1,000 pacemaker implantations and 1,000 cases which also include balloon mitral valvotomy, pulmonary valvuloplasty, and dilatation of coarctation of aorta. He organizes various teaching programs for MD, DN, and DNB students. So welcome, sir. Sir has been part of shaping even school students and postgraduate students across cardiology, sir. Welcome, sir. So we will also take the question and answer in the chat box session, which the audience can forward to us. And now I invite Professor Dr. Vivek Gupta to start his presentation for the role of beta blockers in heart failure, sir. Please, sir. Welcome, sir.
Dr. Gupta, nice meeting you.
Thank you so much. It's a pleasure to speak to you.
It's a pleasure to be with you, sir.
Eric, how are you? Good, doing well?
Absolutely fine. You look as if you're still in hospital.
Yeah, still in hospital. I just finished one angioplasty, then I have to take rounds. So, okay, but actually a little problem. I'm not able to zoom out completely my Zoom show. So okay, now it's better. Okay, thank you. So, first of all, I'm thankful to the Mr. RP and other people and Mr. Milan and to have a direct relationship and with the company, not only with the company, but also with Mr. Dr. Eric Borges, who's a good friend. So, I'll start and limit my topic for 20-25 minutes and then we will do this. And thank you for the nice introduction. I can see a lot of people and the clarity is good enough. And let me see myself first. I'm not able to see myself. Okay, so it's okay. So I'll start sharing the screen now. Let me do something good with my apron. Okay, so let me start sharing the screen. Can I start now?
Yes.
Okay. The topic is exhaustive and okay, so beta blockers in heart failure. The beta blocker, the hypertension will be covered by my friend Dr. Eric and Borges. So I'll start immediately with the topic, and this is my little work in the cath lab and cardiology. This is how we've been meeting Honorable PM earlier since 2011. So I want to introduce that Dr. James W. Black, a Scottish pharmacologist whose discoveries of beta blocker and another class of drugs, which was actually ranitidine, extended the lives of millions of people with heart and stomach disorders and earned him a Nobel Prize in 1998. He died in 2010. So Dr. Black, he did two discoveries. One was, of course, ranitidine. Another was beta blocker. And beta blocker actually saved so many lives. And we can see his picture. He born in 1924, died in 2010. A Scottish pharmacologist, not a cardiologist, a pharmacologist. My father has been pharmacology. So he had he did medicine and then he did pharmacology. So he had worked with him for some research purpose. So I know his name very well. So coming on to the plan of presentations, we have to salute these guys who have done the wonderful job for the community, for the world, and for the patients of heart failure, hypertension. Beta blocker has been done a wonderful things, and we all use it. So the plan of presentation will be effects of beta blockers, beta blocker overall usage country-wise. I'll skip these 2 points, hypertension with CAD. I'll come directly to heart failure, which is two types, reduced ejection fraction and preserved ejection fraction. There is still some data which shows that beta blocker is still underused. And we will directly jump to the various types of beta blocker, bisoprolol, and there are some slides which show about bisoprolol versus other beta blockers. So coming on to the effects of beta blocker, this is how the pathophysiology goes. So how the beta blockers work. This is heart, sinus node, AV node, artery, ventricular muscle. I hope there are a lot of physicians also listening, so I have to be little on the basics as well. Not only cardiologists, but also basics. So just to revise, we all know as a pharmacology, we have been reading pharmacology, it slows down the SA node responsible for initiating the heartbeat. It reduces the heart rate. It increases the AV node refractoriness, slows the ventricular response on atrial fibrillation and atrial tachycardia. That's why beta blockers, AV node blocker is very important therapeutic treatment for atrial fibrillation to reduce the ventricular rate. Not convert the ventricular rate into the sinus rhythm, but reduction. There are three treatment modality. Just to revise the pharmacology for the physicians, whenever there is a atrial fibrillation, you would like to have ventricular rate which is controlled. Beta blocker, calcium channel blocker, and digoxin. These are three medicines, of which the most common usage is with the beta blocker. Of course, diltiazem and other calaptin type of medicines can also be used. It dilates the RC, it lowers the blood pressure. It reduces the contractility. So this is important. Reduces the myocardial contractility and cardiac output. So how can a drug which is reducing the contractility can be useful in the heart failure where there is already reduced ejection fraction? This is important to know. It suppresses the formation of ventricular arrhythmias. That means it also reduces the ventricular arrhythmias. So the overall usage in the country, the heart failure medications, if we see overall, then I will have comparison with the Western Europe and India. And of course, we will also have other countries. So coming on to the beta blocker, ACE inhibitors in blue, and purple is mineralocorticoid receptor antagonist. These are three major important, of course, very important usage is ACE inhibitor and ARB in all heart failure. So if we see overall 80% usage is with the beta blocker. This is a maximally used drug, even more than ACE inhibitors. Similarly, in India also it is the same. And Western Europe, it is still 90% patients of heart failure are on beta blockers, while 80% overall, and India it is about 70. That means it is less than other countries. If you see the Middle East, this is data between Middle East, they're using almost 100% patients. Of course, there are contraindications where it cannot be used. Similarly, if you see the other loop diuretics are very important treatment protocol for the patients of heart failure, all patients who go in the overload, to reduce the to increase the diuresis. So overall diuresis, digoxin is the only compound which increases directly the myocardial contractility. If you see, the usage is very limited. In India, it is about 10-15%, while other Asia, and overall, it is only 20%. So digoxin was again a very important innovation. It happened in the early 19th century, and in fact, it was the only compound which increases the cardiac contractility, and it was once upon a time, it was very big, much used, larger use of digoxin because it was, but it has got a limitation because it has to be used very, very carefully. Any arrhythmia, any electrolyte imbalance can lead to dangerous side effects of ventricular arrhythmia. That is why it is limited in usage. So beta blocker in hypertension, I'm just skipping all these slides because I could not find time to skip over. So I'll take the permission from the chairs to skip those slides. Coming on to the beta blockers in heart failure, and there are two types of heart failure: beta blockers with reduced ejection fraction and beta blockers with preserved ejection fraction, which is diastolic dysfunction, which leads to congestion in the lungs, and the patient is actually breathless and orthopedic. So mostly we are treating reduced ejection fraction patients. So coming on to the beta blockers heart failure with reduced ejection fraction. This is an important slide. It's a huge slide. If we start from 1960, 1970, 1980, 1990, 2000 and 2016. If you see the history of landmark chronic heart failure trials, we started with this. Earlier it was spironolactone and captopril were being majorly used. Recognition of neurohormonal activation happened in 1980 to 1990, and actually Swedberg et al. In Lancet British Heart Journal was the first to publish some efficacy of beta blocker. And then of course we all know the consensus trial, SAVE trial, ISS4, SOLVE a trial with Valsartan, heart failure trial, the RARE trial and TRACE trial. These were the trials which initially happened. From 1990, of course, there were trials which happened for the ACE inhibitors as well. For losartan, there were trials for Optimal, Valhalfrat, Elite trial, this is. And for the beta blockers, the CBIS, UNC, Merit Heart Failure, CBIS 2, Comet Seniors, and CBIS 3. They have been the VET trial, important trial. And of course, for the AICD, that means for the device, you have Medit 2 care heart failure and Medit CRT devices for the heart failure, which prevents sudden cardiac death. So this is all just to revise. For the beta blocker, if you see, the propranolol came in picture 1960, but the usage started only when we had a trial which showed the efficacy in heart failure. This is how it works. In general, heart failure requires treatment with diuretics. Very important, especially the loop diuretics. Then of course second is beta blocker. Then we have ACE inhibitors or ARB, and of course aldosterone antagonist. These are the 5 landmark things. If you see this, in the absence of treatments with proven benefit in worsening heart failure, the best strategy is to prevent such worsening. That means if you have ejection fraction of 40%, let it remain at 40, or 30%, let it remain at 30. The worsening should be a little avoided. So this is what this is. And the building blocks of therapy is such that if you see, the first block is the treatment, medical treatment, mineralocorticoid receptor antagonist, ACE inhibitors, and beta blocker. This is the first building block. The second is, of course, if you fail here, if you are not able to succeed, then of course automatic intracardiac defibrillator. Then you have CRT, which is cardiac resynchronization treatment. Then you have ventricular assist devices. Then of course lastly it is the transplantation. So this is how it feels. So I am telling you that first building block is of course a medical treatment, and we have to be sure about this medical treatment, that we have to do it optimally and with a control and test and regular. So myocardial injury, this is how the pathophysiology goes. If you see the pathophysiology, then vasoconstriction, the myocardial injury with reduced ejection fraction leads to vasoconstriction, increased sympathetic nervous system stimulation, increased norepinephrine, adrenaline, blood pressure, heart rate, and this is how the body behaves. So this is something detrimental, and that is why renin, angiotensin, aldosterone, this is also activated, leads to sympathetic tone, aldosterone hypertrophy, but this is detrimental to the heart, and that is why ACE inhibitors are useful. So this was better. What precedes heart failure? That means what leads to heart failure? We all know hypertension, prolonged hypertension, diabetic patient, high risk coronary artery disease, and of course it leads to LV dysfunction and leads to chronic heart failure. We are talking about chronic heart failure. At the moment, we are not talking of acute heart failure, which can happen in any patient of acute MI, which leads to orthopnea, severe LV dysfunction, and patients sometimes require ventilator and very high level of treatment with noradrenaline, and a patient goes into cardiogenic shock and you require primary PCI. So we are not talking of that. We are talking all of chronic heart failure, which is slowly progressive reduction in LV functions. So therapy in heart failure with reduced ejection fraction. HFrEF. This is what it says. Heart failure with reduced ejection fraction. Benefit of drugs and devices, heart failure. We all know that ACE inhibitors, I'm just repeating, few slides are repetitive, so don't mind. But this also helps the patients and people who are learning. ACE inhibitors, ARB, beta blockers, mineralocorticoid receptors inhibitors, and of course I told you inflammation therapy and IAICD. However, despite all this, in the patients of heart failure with reduced ejection fraction, the 5-year mortality remains around 50%. This is as bad as cancer. Whenever I talk of carcinoma in any patients, whatever it was, breast carcinoma or neurogenic tumor or whatever, you talk of 1 year mortality, you talk of 2 years mortality, but in heart failure, whenever we talk with the patients, we never tell that 5-year mortality is 50%. Otherwise, patient will be so scared that he will think that humko to cancer se zyada kharab bimari ho gayi. So, but of course, but this is the fact. We should understand that we have to find, if we are doing optimal medical therapy, despite that this is there. So pharmaco-invasive therapy, this is what we told, that angiotensin in converting enzyme inhibitors, ARBs, beta blockers, digoxin. Digoxin is still there in the armamentarium. Diuretics, blood vessel dilators, aldosterone antagonists. But we are now talking about beta blocker in the next few slides. The full basket, as I told you, is ACE inhibitors, beta blocker, aldosterone. This is a few slides which repeats. But of course, we always add statins. It has a pleiotropic effect because in 90% or 80% of cases of heart failure, unless it is a idiopathic dilated cardiomyopathy, the most common cause of chronic heart failure is actually coronary artery disease. But of course, there are other diseases like valvular heart disease where you have aortic regurgitation, aortic stenosis. This can also lead to chronic heart failure. But in those cases, we treat the treatment. That means if you treat aortic stenosis, ejection fraction will jump back. If you replace the valve or do TAVI, which is transcatheter aortic valve implantation. Dr. Borges, let me share with you, I had the pleasure of working with Professor Alan Crivier for 2 years. And at that time, 1996 to 98, when we talk of TAVI, it's going a little away from the main topic. So at that time, he was developing the idea only. And that time when I was in the car once with him, he was taking me somewhere. I was a very precious fellow for him. 2 years. He said, I'm trying to replace the aortic valve with non-surgically. So things which blew out of my mind. I thought how it is possible. And he was keeping some documents at that time. So the animal experimentation started during that time. And he did the first case in April 16, 2002. It's almost 18 years. So I'm talking of that time. So TAVI was developing. And I had the pleasure of working in few animal experimentation he was doing in pigs, those developing the valve. He was a very passionate to develop this thing. Now TAVI everybody is doing. So coming back to the topic, the full basket of CAD plus CHF with histolic dysfunction is of course all these things, but digoxin is still in green. That means in some patients you may still require usage of digoxin, the very limited usage. So evidence-based use of beta blocker in 2017, this is the older slide, I'm skipping this slide. Reconciling the guidelines with reality. The desired state, triple therapy, ACE inhibitors, beta blockers, and mineralocorticoid receptor antagonist. So you have NYHA class 1, continued triple therapy. NYHA class 2 to 4, sinus rhythm, heart rate more than 70. If it is there, then you have to add ivabradine. And of course, you have to switch ACE inhibitor ARB to ARNI. ARNI is a new thing, which is sacubitril. We all know this works a little better as compared to alone ACE inhibitors or ARB. The entire triple therapy titration to maximum tolerated or targeted dose should be completed within 4 to 6 months of initiation. This is a conclusion from Canadian Journal of Cardiology in 2016. That means when you are facing for the first time the patient, you should complete all those things, switching and switching on and switching off with beta blockers, titration of dosage. At least within 4 months, you should be able to achieve that. So treatment again, if the patient has CKD or no CKD, the difference is not much. But of course, in CKD, you have to be little careful with the ACE inhibitors and ARB. But beta blocker, there is absolutely no reason to work and to fear from that. So the starting dose for the beta blockers for bisoprolol is 1.25 milligram. And the target dose is 10 milligram OD, depending upon the blood pressure. Whenever you try starting beta blocker or ACE inhibitors in heart failure, normally all these patients have a lower side blood pressure. I'm talking for general physician, not for Eric. So they have a lower side blood pressure, most of them. So we are always have a challenge that how much optimal dose you can achieve. Similarly for carvedilol, which was of course one of the treatment with NHIA class 4, this is one of the compound which is indicated. Metoprolol you give when you have an ejection fraction of 20% or less or 25%. It is more safe to start this carvedilol rather than metoprolol or bisoprolol. So these doses are here defined, but you have to titrate according to the blood pressure. Block sympathetic nervous system, beta blockers, starting dose 1.25 milligram for bisoprolol and 3.125 milligram for BID. Hold of titration unless fluid status is stable. And you have to actually dehydrate the patient. Your lungs should be clear, axis should be okay, left ventricular antiastolic pressures on echocardiography should be normal, almost normal, and CVP, central venous pressure, all these things, hemodynamics, can be done, achieved by good 2D echocardiography. You have to optimize all these drugs depending upon the echo status and left ventricular ejection fraction, as well as left ventricular and diastolic pressures and central venous pressure. Low blood pressure, tips for optimizing the medication. If the patient has low blood pressure, something like 100, whenever we are talking about, I'm talking of general, we are not talking only about blocker, but I'm talking general, especially for ARNI. They said 50 milligram BD, so I'm a little confused whether with the 100 systolic blood pressure what to do. But here, for the beta blocker, use bisoprolol rather than carvedilol. More beta 1 selective. Give beta blocker with meals, slow absorption. Consider decreasing diuretic, reduce the diuretic dosage. Consider volume depletion or other meals. That means if the volume is depleted, depletion is there. When trying to titrate ACE inhibitors, ARB or beta blocker, consider only increasing the PM dosage. If tolerated, then increase the AM dosage at the next visit. This is a guideline coming from one of this. Mortality in heart failure with reduced ejection fraction remains high. I told you the lifespan is 5 years. Average lifespan of heart failure with a reduced ejection fraction. Approximately 1 in 4 heart failure patients is readmitted to hospital within 1 year of discharge. If you see ACE inhibitor, if you see beta blocker, 34% reduction in mortality. This is CBIS-2 trial which is suggested. That means of ACE inhibitors, ARNI or mineral cortical receptor antagonist, the trial have shown, this is paradigm heart failure trial for ARNI, which is being very much talked about recently with the introduction from the companies, and this is only 20% reduction. But with beta blocker, it is the maximum. That means if you don't skip beta blocker, the question is, that means not alternative. If you have to give beta blockers, of course, add on other things. This is what I mean to say. This is American Heart Association medical therapy for stage C heart failure with reduced ejection magnitude of benefit demonstrated in the RCT randomized clinical trial. And this is again to repeat the same thing. The beta blocker had this is American Heart Journal 2012. The beta blocker was having 41% reduction in heart failure hospitalizations versus 31% with ACE inhibitors versus 35% with aldosterone antagonist, and of course with nitrates and hydrogen, which is vasodilator, only 33%. So here also beta blockers in reduction in heart failure hospitalization, 2012 study, not too far, not too old, American Heart Association. That means beta blocker has to be one of the major armamentarium in the treatment of heart failure other than other treatment. Effect of beta blockade on all-cause mortality by etiology. By etiology, that relative risk and 95% confidence interval. CBIS-2 trial I would like to compare here, class which has shown the reduction in mortality to the maximum. And similarly, Merit heart failure trial and US carvedilol trials. So why beta blockers are still underused? If you see this, beta blockers are still underused or withdrawal, which is about 10 to 40%, despite its major proven utility in all causes of reduced heart failure, reduced ejection fraction heart failure. Age-related impairment, visual, hearing, cognitive dementia, functional limitations, social support, polypharmacy, errors in self-administration. There have been few hypotheses why the patients sometimes stops using it. Relative physician healthcare system, conversation, specialty, disease management programs, telemedicine. But there are a lot of reasons why it is being underused still. Is there a class effect? Coming on to the class effect, various types of beta blockers I have not mentioned earlier, but we all know, coming from atenolol to metoprolol to bisoprolol to carvedilol, and then of course a few more are being starting with propanol. Actually, propanol was the first to be, which is alpha beta blocker. It's not a very highly selective, it is a non-selective beta blocker, and then bisoprolol. So annual mean follow-up, if you see the data from Merit heart failure, which is for metoprolol, and CBIS-2, which is for bisoprolol, the percentage risk reduction overall is almost the same. Except for the bisulfite, which is the best trial, which is not an important trial, it is only 10% risk reduction. But overall, 34%, 35%. This was published in Lancet in 1999. Merit heart failure was a very old trial, 1999 trial. So it is, but still we have to follow these trials because they have been large number of patients were randomized, very huge number. Coming on to the bisoprolol versus Pacibolo, which is CBIS2 trial, risk reduction is 34%, which is a very high level. So I'm coming Copernicus trial, which is for the carvedilol, and Merit heart failure trial, which is for metoprolol. All are having something like 30-35% reduction, risk reduction. But for carvedilol in US carvedilol program, 65% reduction overall beta blockers. So major placebo versus control trial of beta blockers supporting heart failure guideline recommendation. I have told you 1999, 2000. This was told in the last slide also. So beta blockers for heart failure with reduced mid-range and preserved ejection fraction. And preserved ejection fraction. This is another thing which I want to discuss with you. The effect of beta blocker over the LV spectrum. That means ejection fraction of 35% to 39% and more than 50%. Lot of patients, they have heart failure because of the increased stiffness of the diastolic dysfunction. That means the ventricle is not able to relax completely, and that is why finally the blood and it goes inside the lungs, and that is what is known as LV lung congestion and leading to increased pulmonary venous hypertension and leading to breathlessness despite having a normal. Here also beta blockers have shown improved results in these two trials which has been published in this there. Coming on to the bisoprolol, this is a different slide. Heart failure for whom? Post-MI hypertension with CAD and elevated heart rate. Sorry, this is a different slide. Bisoprolol, beta-1 receptor selective. No adverse effect on lipid metabolism. This is advantage. If you compare the advantage of bisoprolol versus other beta blockers like carvedilol or metoprolol, beta-1 receptor is highly selective, is a preferred beta blocker for heart failure and then hypertension under MMP guidelines, medicine management program. There's no adverse effect on lipid metabolism. There's no adverse effect on glucose metabolism. What is glucose metabolism? For the physicians who may be listening, beta blocker does not increase the blood sugar, but it causes disturbance to that extent that if the patient has got hypoglycemia, then clinically it will not be discernible to that extent to the patient. And of course, it has got adverse effect on lipid metabolism, but the two side effects of beta blockers on glucose metabolism. One is difficulty in understanding the hypoglycemia, and second is, of course, it may increase the blood sugar levels very slightly to a certain extent. It is better than atenolol, as good as newer drugs, better 24 hours coverage. This is another advantage of bisoprolol, that it has got better 24 hours coverage. Sustained blood pressure control over long term and no sudden changes during exercise. So this is a study which was published. I'm not able to see when it was published, but it's important. BMJ in British Medical Journal. The article for bisoprolol is safe and effective in stage 1 this is for hypertension, doctor, but also this was basically for the hypertension. So we're talking of actually hypertension, which Dr. Eric Borges Vital. This was bisoprolol versus losartan. I'm skipping. But systolic dysfunction, selective trials of beta blockers, as we have told that bisoprolol, the study which has confirmed the CBIS2 trial has shown. I'm skipping few slides in the interest of time because there have to be some questions. So I'll slightly jump angina trials. I'm skipping heart rate reducing effects of bisoprolol in Japanese study with chronic atrial fibrillation. Of course, any beta blocker will reduce heart rate because they all are AV nodal blocker. This was February 2030, and which has concluded that this is the first quantitative analysis of beta blocker monotherapy in atrial fibrillation patients. Bisoprolol exhibits a dose responsive heart rate reduction when administered at sequential dose of 2.5 milligram and 5 milligram daily. Coming to the last part of my presentation, which is bisoprolol versus carvedilol, there are few studies which are there. This was published in 2011. It has the difference between bisoprolol and carvedilol patients with chronic heart failure and COPD. This is a big advantage of bisoprolol. That means the patients generally, whenever the patient has chronic obstructive lung disease, all beta blockers cause worsening because they cause bronchoconstriction. How they cause bronchoconstriction? Because of the beta receptors which are there in the alveoli, and that is disturbed, and that leads to bronchoconstriction. And I've seen many patients in my clinical practice, that means even patients who do not have COPD, they start having some dyspnea, and I reduce or take off the beta blocker, which could be metoprolol, and the patient gets well. So that is the one sign that you can switch from beta blocker, metoprolol to bisoprolol, and you may not have the similar problem with those patients who start having a mild breathlessness because of bronchoconstriction induced because of highly selective beta-1 activity. The beta blockers frequently cause adverse, and this 49% could tolerate the target dose. Bisoprolol induced demonstrable improvement in pulmonary function. It also has some study, this study has shown that this can improve the pulmonary function and cause less adverse events. This is Cardiologist versus beta blocker, Japanese experience. I'm skipping this. To summarize, heart failure is an abnormality of structure function of functions, and the most common cause of heart failure is coronary artery disease. Most frequently reported signs and symptoms of heart failure are dyspnea, edema, and cough. Heart failure is a complex pathophysiology involving activation of two key neurohormonal systems, renin-angiotensin, and this has to be blocked by giving ACE inhibitor or ARNI, and sympathetic nervous system, this is blocked by beta blockers. These two are actually happening because a body response. I repeat again, why beta blockers are effective? Heart failure has a complex pathophysiology involving activation of two key neurohormonal systems, which is renin-angiotensin aldosterone system, and second is sympathetic nervous system. Beta blockers support this area, while ACE inhibitors and mineralocorticoids, they will receptor antagonists, they will support this area, and the patient gets better because of this. CBS-3 trial published in 2005, cardiac insufficiency bisoprolol study. This has shown, I just jump directly. They have compared beta blockers, bisoprolol versus ACE inhibitor enalapril. Very important study, direct comparison. And combination beta blocker is also there in 6 to 24 months. And the CBS-2 trial has shown, CBS-3 was the first such trial to compare the effects of beta blockers first strategy with that of ACE inhibitor first on the hard endpoints of mortality and hospitalization. It showed that bisoprolol first and enalapril first groups were comparable with regard to primary endpoint, all-cause mortality or hospitalization, all secondary endpoints. Moreover, bisoprolol first showed a trend towards improved early survival, 31% reduction in first-year mortality. This suggests that during early treatment of CHF, before combination therapy can be initiated, a beta blocker first strategy may be predicted to improve survival, allowing a greater number of patients to subsequently benefit from combined beta blockade and ACE inhibition. Just to summarize, this is a very important trial. That means normally ACE inhibitors take the priority in starting the treatment protocol, and then you add beta blocker if the blood pressure is on the lower side. You cannot start. In this study, they compared, there are two groups. One group was where they had the ACE inhibitor first, another group was where they had a beta blocker, which was bisoprolol first. And they found that there was some trend favoring that beta blockers first as compared to ACE inhibitor first, which was enalapril, 2005, and because of the improved early survival, and then of course you can add both of them. It's not saying that you can't give both of them. You have to give both of them. But which one to give first is the patient who achieved higher dose of study drugs. So this is, I repeat this, the bisoprolol first and enalapril first strategies showed similar efficacy for the combined primary end of mortality for all-cause hypertension and similar safety. Compared with the enalapril first strategy, the bisoprolol first strategy significantly reduced sudden death during the first year of treatment by 46%. So again, for the physicians who may be listening, normally we start ACE inhibitors or ARNI, and we of course start, if the patient can tolerate, we add at the same time beta blockers. If there's some tolerance difficulty, especially with the blood pressure, we can start bisoprolol first, especially it has shown the reduction in sudden death because it has got anti-arrhythmic properties as well, which ACE inhibitors or ARNI does not have. So reduction, because of the anti-arrhythmic properties which all beta blockers have, there is an edge over starting enalapril first versus beta blocker first in this slide. So this was one last trial, if Eric can allow, if chairperson can allow, titration to target dose of beta blocker versus carbidopa in elderly patients with heart failure. Bisoprolol is the preferred beta blocker for the treatment of heart failure angina is a license for hypertension once daily dose. Conclusion of this study, which was there, despite some setbacks, beta blockers still come closest to all purpose cardiopathy. So this was the final slide, actually, not this a general slide, that despite some setbacks, beta blockers still come closest to providing all purpose cardiovascular therapy with a conspicuous absence of any benefits for lipid problem. There is a plethora of beta blockers, evidence-based selection needed for specific condition. Two advantages of bisoprolol, as I told you, that glucose metabolism and lipid metabolism, but it's a discretion of the the physician, whether to use metoprolol but carvedilol, I would still say, is number one beta blocker to be used in chronic heart failure with a reduction of ejection fraction, that means class 4 heart failure. We start with a very low dose, reduction of ejection fraction less than 20-25% or 15%, where the patient is orthopenic and lying down. But for acute heart failure, there is no clear-cut guidelines for beta blocker. We can't use beta blocker. In acute heart failure, we have to give the vasopressors if the patient has cardiogenic shock. And then, of course, we have to give diuretics intravenous, other things. To conclude, beta blockers are very important armamentarium for treatment of heart failure, chronic heart failure, both in reduced ejection fraction as well as in preserved ejection fraction. And we have shown so many trials. It should not be missed by anybody just thinking that it is reducing the cardiac contractility. It has to be used. And finally, I have told you the advantages of various but this is the last outcome that matter most to persons with heart failure. This is the mortality, hospital visits, treatment side effect, complications, psychological health, independence. So whether we can reduce further more than 5-year survival, 50%, whether we can go something ahead of that, only time will tell. Thank you very much for inviting me for this webinar, and I would like to happily take questions, but after listening to my friend's talk, which is Dr. Eric Borges, who will talk about hypertension, the role of beta blockers in hypertension. Thank you very much.
Thank you, sir. Thank you so much. I now invite Dr. Eric Borges, sir, for his presentation, sir. Please.
Vivek, thank you very much. It was a pleasure listening to you. Masterly presentation as usual. I am sure the audience will be delighted to have listened to you and learned so much from your experience and expertise. So I'm going to share my screen with you guys now. And my topic is a little different from what I was supposed to speak upon because there was some confusion. So I decided to take a little broader subject and to show you what has happened to beta blockers ever since they were introduced into our armamentarium. And I was delighted that my friend Vivek, he has absolutely shown a great respect as far as history is concerned, because he did talk about the history of Dr. Black having invented propranolol. But even before Dr. Black, there was...
Dr. Eric Borges, sir. Sir, I'm sorry to intervene. Could you put it on the slide mode, sir?
I am on slide mode.
No, sir, slideshow mode. Just the next button.
Yeah, I am on slideshow mode. It is not coming to you on slideshow? I'm sorry.
Yes,
I thought
sir.
it was. Is that okay now?
Yes, sir. Yes, sir. Thank you so much.
Okay, right. Sorry. So it was Raymond Alquist who discovered both the alpha and the beta adrenoceptors in 1947. And it took 15 years, of research before Dr. James Black, as my friend Dr. Vivek mentioned, he invented propranolol. And then, as again mentioned by my friend Dr. Vivek, another 15 years before he invented cimetidine, or Tagamet as we used to call it in those days. For years and years and years, I joined medical school way back in 1970. And at that time, all that we had was propranolol as far as beta blockers were concerned. And initially, the beta blockers were used only for the treatment of hypertension. Some patients with ischemic heart disease got it, and some people with thyrotoxicosis or hyperthyroidism. And we as medical students were warned about the side effects of the original beta blocker propranolol. we could not give it to people with asthma, COPD, heart failure, peripheral artery disease, diabetes, dyslipidemia, and those with bradyarrhythmia. And I am sure that all over this country and in many other countries in the world, these contraindications have stuck in our mind so much, even today, that we do not use beta blockers optimally, even in patients who have these conditions, but who are worthy of receiving beta blocker treatment. My friend Dr. Vivek has already told you about heart failure, where beta blocker is today considered to be a frontline drug in the treatment of heart failure. Way back, it was contraindicated. So all of us know about the selectivity of beta blockers. You have the non-selective ones, which was the original propranolol, pindolol, which really never entered our country significantly. Sotalol we have available, but is basically being used as an antiarrhythmic drug for the control of ventricular arrhythmias. Timolol is basically being used in eye drops by my ophthalmology friends for glaucoma. Then the non-selective beta blockers, the alpha and beta blockers, labetalol, carvedilol, and the beta-1 selective blockers, all of which are listed down here. Now, out of these, I must mention two beta blockers which are extremely, extremely important. One is bisoprolol, very highly beta-1 selective blocker, and nebivolol. Nebivolol is even more highly selective and more powerful beta-1 blocker than even bisoprolol. So we'll talk about a little on it, but the subject is so vast and wide that I have to move a little fast. Now, the mechanisms of beta blockade, I think Dr. Vivek Gupta has already alluded to most of them. So I'm really not going to spend too much time on it. But remember, the more selective you are in the beta blockade, beta-1 blockade, the better it is for the lungs. You will not get any asthma, COPD aggravation, and so on and so forth. And of course, it acts on multiple systems in the heart, the conduction system of the heart, it acts on the heart muscle, it reduces blood pressure, so on and so forth. So I'm not going to spend too much time on this. Now, the advantages of using highly selective beta blockers is that you have the lower chances of bronchoconstriction, less interference with carbohydrate metabolism and the lipid profile. You have decreased in the incidence of cold extremities and Raynaud's phenomenon you see very infrequently if you use selective beta-1 blockers. Less impairment of exercise tolerance. This is very important because if you use non-selective beta blockers, patients get fatigued very easily. Even though if you examine their cardiovascular system, there is nothing significant you can find, but take them off the non-selective beta blockers, introduce a beta-1 selective blocker, and their fatigue disappears. And of course, the last one is not important. We are not neurologists to treat essential tremors. Now, remember that beta blockers have a huge effect on the entire cardiovascular. Look at the circle. Let's start with myocardial infarction on the top. The myocardial infarction can lead to neurohumoral activation, which of course beta blockers blocks. Myocardial infarction can cause arrhythmias and then lead to sudden death. Beta blockers helps there. The myocardial infarction, cardiac damage causes remodeling. Beta blockers also helps to prevent too much of remodeling. Beta blockers also does not allow too much of ventricular enlargement. Beta blockers, if it has to be used, you can treat heart failure and it can prevent death. Beta proven effect on atherosclerosis, particularly nebivolol, which has got a nitric oxide donating effect and therefore helps endothelial damage. It can prevent coronary artery disease to some extent, can prevent myocardial ischemia, and so on and so forth. So you can see from this slide that there is a pronged multifactorial effect of beta blockers, which makes it perhaps the most advantageous drug for the treatment of heart disease or cardiovascular disease that has ever been invented. Wide spectrum of action, wide effects right across the entire spectrum. Now, the use of beta blockers insofar as clinical practice is concerned, you use it for hypertension, you use it for angina, myocardial infarction, cardiac arrhythmias, heart failure, hypertrophic obstructive cardiomyopathy, dissecting aneurysm of the aorta, and of course the non-cardiac uses, which I'm not going to spend too much time on. So you can see there's a huge role for beta blockers in the treatment of cardiovascular disease. So we come to this pendulum. The pendulum has swung from 1962 when it was invented, where there were so many contraindications. Most of those contraindications have gone today, and the pendulum has swung to the other way, where people with heart failure, you give them beta blockers. Patients with COPD, you're not worried about giving them beta blockers because you have selective beta-1 receptor blockers available today. So, in a nutshell, the original contraindications for beta blockers or indications where you had to be very careful were because of the non-selective part of the beta blockade. Today, we know that it is an excellent drug for heart failure. In fact, as Dr. Vivek pointed out so lucidly in his talk, it has become mandatory for almost all cases of heart failure to receive beta blockers. And in some countries, as he showed you, the use is as high as 90 to 95%. Okay? We still have to be a little cautious in COPD, asthma, and in peripheral arterial disease, but not to say that it is contraindicated. By no means is it contraindicated. You can give it safely in these conditions in most patients without causing any aggravation of their clinical condition. Diabetes is not a contraindication at all. You can use it safely in diabetics. Dr. Saab has already alluded to the fact that patients may not be able to appreciate hypoglycemia, but it does not produce hypoglycemia. I want to emphasize that, because many of my students and colleagues do not use it because they are scared of it producing hypoglycemia. It does not produce hypoglycemia. And you can use it safely in the presence of dyslipidemia because it does not, as you will see, alter any of the lipid profile. Now, according to the selectivity of the beta blockers, okay, and you can see here, the increasing beta selectivity of those metoprolol, atenolol, betoxolol, and bisoprolol. Bisoprolol is the most highly beta selective. Nebivolol is not represented on this slide, but it is even more highly selective than bisoprolol. So these two drugs, bisoprolol and nebivolol, should be logically the preferred drugs to be used whenever there is an indication to use beta blockers. Now, if you can see here, if you compare the various pharmacodynamics of the various drugs, you will see that the most favorable ones, okay, are for bisoprolol. Look at the plasma elimination. It stays in plasma for 10 to 12 hours. Look at the half-life. Look at the absorption. Look at the bioavailability. Look at the protein binding. All of these are very, very favorable to bisoprolol as compared to its sister molecules. Okay? So bisoprolol is one drug that you really need to keep in mind. Look what happens to lung function. People are always worried about lung function. Now here is a trial which clearly shows, look at the airway resistance, airway resistance, AWR, right? And look, if you give propranolol, see what happens. See what happens when you give 100 milligrams of atenolol, and see what happens when you give placebo. There is almost no change if you give bisoprolol. The airway resistance stays very marginally affected. See what happens when you give atenolol 100 milligrams. airway resistance
हाँ एक मीटिंग होता है कल में तो आपका फोन आया था मैं कॉल
rises markedly, showing thereby that the higher the selectivity of the beta blocker, the less the problems in the lungs. This is very, very reassuring and comforting to know. See what happens with lipid metabolism in long-term therapy. So you have total cholesterol, LDL, triglycerides, and HDL. Once you give bisoprolol, okay, see what happens to it. There's hardly any change in the level over a period of 41 months. The levels stay almost the same, showing you thereby that there is no significant change in the lipid metabolism if you're using bisoprolol. Okay. Now see in the long-term therapy, okay, when you use the lipid profile just look what happens to HDL cholesterol. If you look at atenolol and you look at propranolol, HDL cholesterol goes down. And as you know, you don't want the HDL cholesterol to go down. You want it to be as high as possible. Look at bisoprolol and metoprolol. The HDL levels stay high. They stay high. They do not change much. Okay? So that's a huge advantage in terms of the lipid profile. So now, we have established that the paradigm has shifted. You want to be beta-1 selective. Okay? And beta blockers were initially introduced for the treatment of hypertension and ischemic heart. Unfortunately, beta blockers for the treatment of hypertension fell into disrepute. Now, what do I mean by disrepute? You'll be surprised to know that atenolol holds the record for the largest prescribed molecule in the history of the pharmaceutical industry. Only recently that record has been broken by the statins, okay? But otherwise, atenolol was the largest selling molecule for the treatment of hypertension in the history of pharmacology. Suddenly, a lot of trials came out where beta blockers were used in evidence, which showed that yes, you could control the blood pressure, but there was no decrease in mortality or morbidity, and some trials even showed an increase in stroke with beta blockers, atenolol basically, and some of them were using other drugs like metoprolol, etc. So beta blockers went into disrepute, right? One of the reasons perceived was that there was no significant change in the central aortic pressure with these beta blockers. So they said if the central aortic pressure does not change, then that's one of the reasons why you do not get a decrease in mortality or morbidity.
Cool.
And other drugs like calcium channel blockers, angiotensin receptor blockers, ACE inhibitors, diuretics, etc., took center stage in the treatment of hypertension. And that remains even today. Even JNC8 has relegated the treatment of beta blockers, okay, to number 3 position. So it's the third choice. JNC8, which is the recent recommendation for treatment of hypertension, okay? They say that you should not use beta blocker first line therapy or second line therapy. You may use calcium channel blocker, you may use ARBs, you may use ACE inhibitors, diuretics, absolutely. But beta blocker is only to be used if hypertension is associated with ischemic heart disease, heart failure, there is disproportionate atrial tachycardia, atrial fibrillation, atrial flutter in order to control the ventricular rate. Sometimes you use beta blockers to control DPCs, okay? If there is aortic dissection, yes. If there is hyperthyroid state, yes. So the role of beta blockers in the treatment of hypertension has shrunk. The pendulum has swung, okay, against the beta blocker in the treatment of hypertension. And I would like to re-emphasize this. You will only use it today in the treatment of hypertension if it has one of the conditions which I listed out here, ischemic heart disease, heart failure, tachycardia, VPC treatment, etc. Otherwise, short of this, beta blockers have no role in the treatment of a garden variety case of hypertension. Okay. Having said that, what do we do with ischemic heart? Okay. Today, all patients with acute coronary syndrome should be given beta blockers on day one, if there is no contraindication. So, acute coronary syndrome, whether it is non-STEMI or STEMI or unstable angina, you need to give them beta blockers if there is no contraindication. There are so many trials, and I don't have time to go into all the details of the trial. I have distilled the results of the trial into these statements, which clearly indicate acute coronary syndrome, no contraindication, you must give beta blocker to almost any and every patient. And you must continue those beta blockers for at least 1 year, okay? Or longer. If, for example, if the patient is in heart failure after acute coronary syndrome, you give it long term, okay? If the patient has ischemic heart, also has hypertension, you would give him beta blockers long term. But if it's a garden variety, acute coronary syndrome, no major risk factors, no LV dysfunction, the recommendation is give it for at least 1 year, after which beta blockers may be discontinued, because many trials have shown that over 1 year, after 1 year, there is no significant benefit for beta blockade in the absence of any other factors which it could help. Okay? Absolute contraindications for beta blockers within the acute coronary syndrome spectrum is, of course, if hemodynamically compromised individuals, including those with hypotension with or without shock, you will not give beta blockers in acute coronary syndrome. Patients with very active bronchospasm, patients with severe bradycardia or heart block, greater than first degree heart block, you will not give beta blockers in acute coronary syndrome. And if the patient has a myocardial infarction precipitated by cocaine use, you will, as far as possible, not give beta blockers, because you can cause a further rise in the blood pressure, because cocaine acts on both the alpha and the beta. You block the beta, the alpha gets unopposed, and the patient may go into a hypertensive crisis. So please remember these contraindications for the use of beta blocker in acute coronary syndrome. In chronic stable coronary artery disease, all of them should receive beta blockers. Those who have LVEF less than 0.40 must receive beta blockers. Those who have chronic stable angina must receive beta blockers. And those who need beta blockers to control ventricular arrhythmias, and those who need beta blockers to control the rate in atrial fibrillation. Okay? So these are absolute indications for the use of beta blocker therapy in chronic stable coronary artery disease. Now, what is the role of beta blockers in atrial fibrillation? Dr. Vivek, my friend, has already alluded to this. You give beta blockers to block the AV conduction and slow down ventricular rate. You are in no way actually treating the atrial arrhythmia or preventing the atrial arrhythmia, with the sole exception of what happens in hyperthyroid atrial fibrillation. Because there is an adrenergic storm that is causing the atrial fibrillation, which will be blocked by beta blockers. So atrial fibrillation caused by hyperthyroid state, you might be able to get away by protecting atrial arrhythmias from coming because of the hyperthyroid state. But all other routine garden variety cases of atrial fibrillation, the beta blockers are only given in order to control ventricular rate. And today we know the controversy still exists, rate control versus rhythm control in atrial fibrillation. Depending upon the scenario, depending upon the clinical condition, one can argue about the benefits of each one of those therapies. Now, what is the characteristics of an ideal beta blocker? Okay. The characteristics of an ideal beta blocker is once daily dosing, very highly beta 1 selective, should be kidney safe. Bisoprolol and nebivolol meet all these requirements. And therefore, I submit to you all that if you have to use a beta blocker, beta 1, make certain it's a beta 1 selective blocker. Make sure that you select bisoprolol and or nebivolol. Nebivolol is now beginning to take center stage in the treatment of coronary artery disease, treatment of hypertension, and other indications for beta blockers because of the so-called advantage of nitric oxide donation by nebivolol. I do not know of any trial which says that nebivolol is superior to, okay, but it is certainly a very effective drug. Maximum work has been done on bisoprolol, and therefore my own clinical practice, I use a lot of bisoprolol for all my patients who fit in with the indications that I have discussed with you. One can keep on talking till the cows come home, but thank you very much. I'll try to keep it as brief and as short as possible. Thank you for listening to me.
Thank you, sir. We have a few questions.
Happy to answer them.
Both the speakers from the audience, sir. Sir, I'll start with you. Basically, this question comes to us from Mumbai. So, you have actually mentioned that there is no role of beta blocker in treatment of hypertension. So, one of the physicians who has joined us from Mumbai, he has presented a case scenario where a patient presents with type 2 diabetes mellitus and tachycardia. So, would that patient actually be started a beta blocker, or is there any contraindication?
I think my friend from Mumbai has misunderstood what I said. I said for a routine garden variety case of hypertension, I would certainly not use a beta blocker. However, if the patient has hypertension associated with inappropriate sinus tachycardia, disproportionate tachycardia, he's in heart failure, he's got ischemic heart disease, okay, then of course I would give him a beta blocker. But a routine garden variety, walk-in off-the-street patient who has none of these factors, okay, has only an elevated blood pressure, am I going to start him as a beta blocker straight away? According to all recommendations, the answer is no. Okay. I would give him either a calcium blocker or a ACE inhibitor, ARB, or a diuretic, depending upon the clinical situation.
Right, sir. Thank you. Thank you. So, second part of that question was the doctor would also like to know which is the beta blocker of choice, especially in such kind of patients for a diabetic patients, or which is the safest you consider as a beta blocker for these kind of patients?
Well, I guess both Dr. Vivek and I, are very clear about this, that for beta blockade in general, irrespective of the scenario, okay, the more highly selective the beta 1 blocker, the better it is. More highly selective it is, it doesn't have much of an effect on blood sugar, doesn't have much of an effect on the lipid metabolism. So I really don't think that there is any issue with that.
Yeah.
The one that I personally use a lot of bisoprolol. I would not be averse to using carbinolol because it's also extremely effective in hypertension, or nebivolol. So these would be my three choices of beta blockers in the scenario of hypertension.
Right, sir.
Okay, Vivek, what would you say?
Yeah, I may add to what Eric has said. First of all, Eric, very nice presentation, basically telling all the details of beta blockers. So when he says the diabetic patient, more highly selective, lesser chances of, you see there is some apprehension also. I was talking that the few beta blockers because of beta 2 activity may cause hyperglycemia. Very, very little when it has been shown pharmacologically. So if you are highly selective beta blocker in diabetics, it's better either nebivolol or bisoprolol. As you say, we all are using bisoprolol. It is safer to use these two because they are more highly selective beta 1 blockers than this. Number one. Secondly, as you say, the garden variety of hypertension, I may a little add. although JNC says that it is the third line, but of course, there is no doubt that if you have an associated disease like acute coronary syndrome or acute or any coronary artery disease or tachycardia, you have to use it as additionally, or heart failure or ejection fraction less than 40%. But I would may add from my personal clinical perspective that even in garden variety, if you are not able to completely control the blood pressure, you may add on a beta blocker. That way you are taking optimal usage of ACE inhibitors, optimal uses of calcium blockers like cilnidipine or amlodipine, and you feel that sometime he has got a labile tachycardia, he's anxious, he says kabhi palpitation bhi ho jata sometimes, it is not recorded. So you may add on this because it's not a contraindication for even third. JNC says you can use it, but try these two first. This is what I said.
Right, sir. Right, sir. Thank you so much for answering the question from Dr. Eric and Dr. Vivek, sir. So there is another question which comes. I'll ask it to Dr. Vivek, sir. Dr. Mohammad Mansoori from Mumbai, he would like to know what would be your drug of choice in acute heart failure patients, sir?
You see, in acute heart failure, the patient is, what is acute heart failure? Acute heart failure means that suddenly within few hours, the patient's ejection fraction has gone down. And most important cause is actually a coronary artery disease or acute MI. In these conditions, we normally treat them in ICU. Patient with heart failure, he has got crepes coming in the basal part of it, and you do X-ray, which is showing pulmonary venous hypertension. You do echo, you can increase LV and diastolic pressure. The most important treatment protocol in such cases is to do excessive diuresis. That is the most important part. Beta blockers should not be used at this point of time because it could worsen heart failure. And once you are done with this, and we always use intra-aortic balloon pump also if the patient is an acute MI to help to reduce the burden on the heart. So the drug treatment will be, I think Eric will also agree with, if the patient you are able to titrate for at least 7 days, then of course you can start it. But in case it is having tachycardia also, you see now that you are safe, you can't use diltiazem. You can't use, because they are negative inotropic and chronotropic effect, or negative inotropic effect. So at this point of time, I would like to use intravenous digoxin if everything is normal, and that will actually reduce the heart rate as well as increase contractility to some extent. And of course, digitalize the patient slowly. Initially, you see the dosage is 0.5 milligram of intravenous digoxin, then followed by 0.25 after 6 hours. Full distillation is to be achieved, and then of course you have the controlled heart rate. You do the digoxin levels, which is around, it should not be more than 2, and then you are able to do it. But of course, digoxin is only temporary, and after that, once the patient is after a few weeks, 2-3 weeks, you can start beta blocker. This is how we manage the patients with. Of course, you can use ivabradine in such cases because that is not a contraindicated. It's a new salt which is a sinus node blocker. It's not AV nodal blocker, because if you have to really reduce the heart rate and you don't want to use a digoxin, you don't have a good setting where you can do a digoxin level, and if electrolytes are not good, that means you have either hyponatremia or hypokalemia, magnesium levels are not good, then ivabradine is a better choice to reduce the heart rate, because heart rate has to be reduced in such acute heart failure condition. You can't work with 130 because if the patient is compounded with a shock, then you are using inotropes also, and that will dopamine or noradrenaline. Noradrenaline is better choice because it does not cause that much of reflex tachycardia, because dopamine and dobutamine, they cause excessive bradycardia. So in our setup, we use noradrenaline if you have to really increase the blood pressure. Mean pressure about 80 or 70 is good enough. And then, of course, ivabradine to be added if you are not very much comfortable with digoxin. But digoxin has an advantage because it also increases our cardiac contractility to a larger extent. So this is how we treat. And when the patient goes into the chronic stage, add on these beta blockers depending upon your choice.
Right, sir. Thank you. Thank you so much, sir. So next question is for Dr. Eric Porges, sir. So Dr. Manish is from Mumbai. He has mentioned that there is a capital RCT study which has shown no benefit for the use of carvedilol in ST elevations and MI with primary PCI. So what is the ideal way of moving forward? Should we use a medical management? Should we use PCI? So he would just like to understand your perspective on this, sir.
Well, it is like this. In acute coronary syndrome, okay, the basic thing is if the patient has no contraindication for a beta blocker, there is no heart failure, there are no bradyarrhythmias, there is no incidence of heart block, he's not asthmatic, he's not wheezing, absolutely I would give a beta blocker. There's no question about it. I would give a beta blocker. Now, you can say that there's an alpha blocker and a beta blocker, carvedilol. It tends to bring the blood pressure down more sharply than is caused by only a beta blocker because of its alpha blocking action. Okay, but universally, I think there is a absolute uniform management of acute MI all over the world, wherever you go. Within the first 24 hours, everybody must receive a beta blocker, which cuts down morbidity and mortality and sudden death in acute myocardial infarction. There is no debate on that. Okay, so whichever recommendations you may look at, European Society, American Heart Association, whatever you look at, beta blocker in the first 24 hours, unless contraindicated, must be given. Okay. Now, I don't think these one single trial here and there means much. You need to have a huge amount of data, real world experience, meta-analyses before you can pick up one single trial and say whether it has got any real value or not. Personally speaking, beta blocker must be given if there is no contraindication whenever you have acute coronary syndrome.
Right, sir. Thank you. Thank you so much for answering that. So, Dr. Vivek Gupta, sir, Dr. Eric Borges, sir, this question might probably best answered by both of you. I leave it to you. So, the audience would like to know the role of ARNI in this treatment of heart failures as well as hypertension, sir, or the order of choice which you would prefer.
Dr. Vivek, you want to go?
Yeah, you're talking of ARNI, no?
Yes, sir.
Okay, second. You see, there have been recent trials and lot of trials, especially when the company with the broad Vimeda and later on, of course, the other companies have come in, which has shown advantage over the existing ACE inhibitors oblique ARBs in treatment of heart failure, in reducing the heart failure hospitalization, and also improving the survival and also increasing the ejection fraction. And we were very much overwhelmed and very happy to see. And when we started using this compound, which came, I think, 2 years back, we really saw clinically the benefit of this compound. And there is a classical pathophysiological advantage, as you see, I don't have time to show because there's a big diagram which has to be explained. And so there is no doubt that as of now, if the patient is in heart failure, if you have to choose between ACE inhibitors, oblique ARB, oblique ARNI. ARNI is the first choice, and which is coming in 50 milligram dosage, and this is twice daily dosage. But of course, you have to titrate the blood pressure because blood pressure reduction by this compound is little higher if you compare with the ARBs oblique ACE inhibitors. So the only thing you have to keep watch. And initially, when I was attending these webinars, I gave a lot of seminars now it's a webinar, and also talking and gave lectures, then they were saying that you should use it even if the systolic or the pressure is less than 100. In my own clinical practice, I'm a little apprehensive. So I debated with a lot of people, why it cannot be 25 milligram twice daily. I'll request Eric to also respond to this query in my mind. So then they said, no, if you break the tablet, the compound is disturbed and the overall things are not so easy. I mean, it is unpredictable. But in my own clinical practice, I started using 50 milligram half daily. And once the patient blood pressure was a little more and we were able to hydrate a little more, because a lot of these patients are already on diuretics orally and reduced, and they have a central venous pressure which we don't measure in a patient who's coming to OPD, must be less than what is expected. So I was trying to keep a balance between intake output. I said, whatever you pass out urine, add 200 and then take that much amount of liquid, because there's an insensible loss from the body, or 300 ml. So if you're passing about 1200, take 1500. If you're passing 1500, take 1800 ml of liquid. It's very important in a patient who's in chronic heart failure, ejection fraction about 20, 25, 30%, because if the balance is gone, the patient will go into orthopneic state and you have a fluid overload and things will be worsening. So I was telling that try to improve your liquid hydration depending upon what you are taking. Try to keep the blood pressure around 100, about 100 or 110. Those patients, there are a lot of few patients I've seen, not many, but few patients are having very good pressure, 130, 140, despite EF only 25%, because they have an intrinsic hypertensive response in the body. There you have no challenge. There, of course, you can start 50 milligram, even 100 milligram twice daily, depending upon the patient choice. But as of now, with the existing trial, ARNI is much more favorable as far as reduced hospitalization, increasing the myocardial contractility, and thirdly, increasing the lifespan. So all these things are there. So now ARNI is a better choice, but you have to keep watch on potassium. When you transition from ACE inhibitors to ARNI or ARB to ARNI, there's some change. Because when you are, if I'm rightly remembering, for ACE inhibitors transition directly to the ARNI, you have to wait for a few 24 hours to 48 hours. For ARB, you don't have to wait. You can immediately stop and start. So this is my view as far as this compound is concerned.
Right, sir. Eric, sir?
Well, I think there is no question that ARNI is definitely one of the drugs which I would use in preference to either an ACE inhibitor or an ARB. Or if the patient was already on an ACE inhibitor or an ARB and he goes into heart failure, I would like to switch them over and give him the benefit of ARNI. Because sacubitril, as we all know, okay, is a neprisilin inhibitor. Okay, and what is neprisilin? Neprisilin is basically an enzyme which degrades other hormones, and the one that it degrades is natriuretic peptide degradation. Okay, so if you prevent that from happening, you are automatically giving a natural compound to improve the heart function. You are preventing degradation of a normal hormone. If you keep that hormone level high, not only do you get natriuresis, you get diuresis, but as Dr. Vivek just said, you get increased inotropy as well. So on all counts, neprisilin wins because you're combining valsartan, okay, which is an ARB, with a neprisilin inhibitor. So I don't think there is any question that it is a superior drug. So my combination in a patient with heart failure would be diuretic, beta blocker, and ARNI. Okay. Then if anything else he may need whatever else he has got. But these three basically would be the drugs for heart failure.
On dialysis, sir.
You mean which beta blocker or which drug?
Which beta blocker to which would be the ideal?
Well, again, I think, as far as beta blockers, all the beta blockers have a problem with, that they can cause erectile dysfunction. There is no question about it. But the more selective you get, the less the erectile dysfunction. Okay? So I would say go as highly selective as you can. Bisoprolol, nebivolol. That would be my drug of choice if I had to give it to any young person. Okay?
That's, yeah.
And the second question was?
The elderly who's already on dialysis or in a dialysis, would you actually use a beta blocker sort of?
No, absolutely. If it is indicated for him for other reasons, okay, like he has heart failure, of course I'd use a beta blocker, okay, or is any other indication, ischemic heart, of course I would give him a beta blocker. So I'm not giving him the beta blocker from the point of view of pure hypertension, no. But if he's got any other associated conditions that demand a beta blocker, I would certainly give it to him without any hesitation.
Yeah, but
all the beta blockers are safe in CKD.
Okay.
This is what CKD is not a contraindication for any beta blocker. It's only the ACE inhibitors or ARB where you have to think twice because you can't give them after the creatinine level is a little higher, more than 3. So beta blockers, CKD, no relationship.
Correct.
And of course, he's very right. More highly selective beta blocker, erectile dysfunction chances are almost minimal because with metoprolol and ethnolol, it is about 10 to 15%, which is quite significant erectile dysfunction. For these highly selective beta blockers like bisoprolol or nebivolol, I think it's a very, very little. If you have a patient of CAD and you have to give beta blocker, try to use these beta blockers, especially in young patient.
Right, sir. So the final question, sir, from my side, which has come from the audience is, would you combine a beta blocker with any other drug like an ARB or an ACE inhibitor for the management? And if you, what would be how would you go forward for that, sir?
I told in my slides, it was very clearly that patients of heart failure patients of hypertension with heart failure or hypertension with CAD. You have to use both of them. So you see, if you have a high blood pressure and CAD, you have to combine both of them. If you have a heart failure, you have to combine both of them 100%, because in heart failure, both ACE inhibitors oblique ARNI plus beta blocker, you have to give it. And there was a trial which I showed, that very important trial, CBS3 trial, which showed which one to be used first. And they have shown a little advantage when you are using the beta blocker, because it reduces the arrhythmic activity, and it is antiarrhythmic as well, which while ARNI or ACE inhibitors or ARB, they are not antiarrhythmic. So you have to use them. There's no doubt in this. Heart failure or CAD, you have to use both of them. If CAD with hypertension.
Right, sir. One final question which we have for Eric sir or Vivek sir. Sir, for a beta blockade heart, or a heart which is actually beta blockade, right? What would be your choice of the heart rate which you wish to keep for a patient? How would you recognize that this is a completely beta blocked heart, or how would you go for management in that?
Well, it's a combination. It's not only the question of the heart rate, it also has to do with the blood pressure, because you're looking at hemodynamics. If, for example, I have a blood pressure which has come down to 120 by 76 or something of that sort, and the heart rate is in the 60s, I wouldn't worry about it. I would not go after a particular heart rate. I would look at the whole profile. I'm not chasing a number. I'm chasing the patient's whole profile. Is he short of breath? Is the angina relieved? Is there any evidence of heart failure coming up as I'm increasing the dose of beta blocker, etc., etc. So you look at the whole profile. I don't chase a heart rate number, but basically, the lower I bring the heart rate, let us say somewhere in the upper 50s, lower 60s, and the patient is otherwise asymptomatic, and I've achieved whatever I want to achieve in terms of his symptoms, then, I'm happy with that number. But I'm not chasing a particular number. I'm looking at the patient as a whole.
Right, sir.
I would may add a little, because you see, if you have a heart rate of 55, I will have a little concern. I'd like to keep, because you see, sleeping heart rate will go further down. So a lot of patients who are there when we do Holter. In fact, I would like to discuss here with Eric. I did a Holter of my son. He's a doctor, and his basic heart rate sleeping is 37, which was the minimum. Because I was seeing his pulse many times, he was 70 is normal for him. So I was a little uncomfortable. I said 37, 35, 36 sleeping heart rate. For people, maybe it's okay, but normally 40, 45. So for not keeping away from that discussion, answering the question, any heart rate which is around 60, 65 is almost good beta blockade, with Dr. Eric saying that blood pressure has to be seen also at the same time. So 37, Eric, what's your answer about this question? 37 sleeping heart rate.
I would leave it alone. You know that the famous tennis player Bjorn Borg, who was Wimbledon champion 7 times, his resting heart rate 33. Okay, sleeping heart rate 24.
But he's not
no problem.
But he's not an athlete. I'm talking non-athlete person.
No, I know, but this is what we call a vagotonic individual. He's a vagotonic individual.
He's a vagotonic individual. But they have more chances, for discussion, they have more chances of vasovagal phenomena otherwise.
Maybe, but I'm sure that when he is moving around, his heart rate must be 70, 75.
It's 80, 90, 100, 102.
Yeah. So I would just leave him alone.
You leave it? Yeah? When thinking of your own family, you have to be a little more cautious.
No, I think give him my best wishes.
He's a doctor, he's around. So he was
right, sir. So just any last comments, because a few people from the audience have just asked your opinion about metoprolol, sir. Any positive or negative side effect?
No, I think metoprolol is a great drug. We have used it a lot, and the only reason why we used it so much in India was because people who were selling bisoprolol were not active at all. It was very difficult to get bisoprolol. While metoprolol was very easily available, so many people latched onto metoprolol. But if you weigh it on a scale, on a tarazu, if you weigh it, I think bisoprolol is any day better than metoprolol, pharmacologically, etc., etc.
But I think another reason is that they have more trials with metoprolol.
Yeah, that's true. But still, I think the trials are all showing the same thing. There's no, yeah.
Right, sir. Thank you so much, Eric sir.
Thank you very much.
Gupta sir, it was really a pleasure having you, and we thank you again for the patient answering and the patiently which you have taken us through the lecture on beta blockers. And thank you, Eric Borges sir. We apologize for any last-minute changes which are happening from our
No,
side.
that's okay. It's all right.
Thank the audience again.
Yeah, is it
Wish
Milan
us-
who's speaking? Maybe is it Mr. Milan who's speaking now at the moment? Who's speaking?
Dr. Birla.
I am Dr. Ashish sir. I work for JP sir.
But I cannot see your face. Let me see.
I am very much here.
Oh, okay, Ashish Birla. Okay, Ashish, you are.
Yeah.
So,
I thank you again, sir, Dr. Gupta, sir, Dr. Borges, sir, and the audience for being patiently asking all the questions. And I thank again the speakers who are patiently answering all the questions for us today. And I wish you a safe week ahead, sir, in the COVID times, pandemic times. It is really a pleasure that we have you today for our meetings.
but my last comment, I should give a full applaud and my congratulations to RP who was really following with me. And I think he's an asset to your company. And Mr. Milan, we have been speaking. But RP Singh has been quite proactive, reminding me every day that you have to do it. I think you have an asset in your this because you see today also I had to.
Vivek, it's a pleasure to see you again.
Yeah, thank you, Eric, and very nice. We'll meet. How's Bombay doing? I'll invite.
Bombay is bad. Bombay is bad in the COVID scenario.
I will invite you to one of my webinars. We have done 17 webinar on COVID with international speakers. 18th is due, and we have Americans, Italians, and Germans cardiologists along with one of the ministers from India for spiritual message. So I'll invite you next time because all of the people except for you have been our partners. Except I think I missed you. That this time I'll invite you for COVID-19 webinar.
Take care. Take care.
Thank you. Thank you, sir. Thank you.
Bye. Thank you very much. Take
Have a
care.
safe stay.
Thank you, RP. Thank you, Ashish. Thank you.
Bye, everybody.
Bye-bye.
Thank you.
Bye-bye.
Thank you, sir. Thank you very much.
So this was actually a webinar on beta blockers. अब बीटा ब्लॉकर क्या होते हैं मैं थोड़ा सा पब्लिक के लिए बता देना चाहता हूँ कि बीटा ब्लॉकर एक स्पेशल दवाइयाँ हैं जो कि हम लोग देते हैं हाई ब्लड प्रेशर में, हार्ट एंजाइना में, हार्ट अटैक में, और हार्ट जब फेल होने लगता है, कमजोर होने लगता है उसमें। तो इस पर एक डिस्कशन था, एक डॉक्टर बॉम्बे के थे और बाकी करीब 700 लोग सुन रहे थे फिजिशियंस में। ये बड़ा स्पेसिफिक डॉक्टरों के लिए वेबिनार था जिसमें कि हम लोगों ने बताया कि कब कब कौन कौन सी डोसेज, कौन कौन सी दवाइयाँ। और बीटा ब्लॉकर एक ऐसी दवा है जो कि जैसे मैंने बताया कि जिसने इसको डिस्कवर किया, जिसने इन्वेंट किया डॉक्टर ब्लैक, उनको नोबेल प्राइज मिला। यानी कि इतनी बड़ी दवा है कि इसके लिए, इसकी डिस्कवरी के लिए उस आदमी को नोबेल प्राइज मिला। इतना यूजफुल दवा है। इट रिड्यूसेस द मोर्टेलिटी, इट रिड्यूसेस द हार्ट फेलियर, इट रिड्यूसेस द एंजाइना, इट इज बीइंग गिवन बाय एवरीबॉडी। तो उसके स्पेसिफिक पॉइंट्स को हम लोगों ने डिस्कस किया इस वेबिनार के थ्रू। एंड जेबी केमिकल एक कंपनी है जिन्होंने, और साथ में मिस्टर दीपक और जो कि हमें फॉलो करते रहे, और हम लोग के थ्रू बड़ा बिजी शेड्यूल रहता है हम लोग का, लेकिन ये वेबिनार में पार्टिसिपेट करके डॉक्टरों को अवगत कराना था कि किस तरह की दवाइयाँ, यानी कि इसके जो सुनने वाले लोग थे वो 95% डॉक्टर्स थे ऑल ओवर